Hi everyone, it's Hunter Hicks. Today we're going to look at some medications for the common cold, cough, and allergic rhinitis. Common things we're going to see as we are coming up on cold season. This was recorded in August, so right around the corner. Now, when we look at allergic rhinitis, which is really what we just call allergies, now it can sometimes be triggered by non-allergic things, but usually allergies. We see the immunoglobulin or antibody, IgE, bind to the mast cells. When it binds to the mast cells, we get release of its granules inside it. So things like leukotriene, prostaglandin, and histamine. That's why by blocking some of these, what some of these medications do, we'll have less of those signs and symptoms. Common things like runny nose, conjunctivitis of the eye, scratchy throat, all the common things we do see here. Now, intranasal glucocorticoids like Nasacort or Flonase are great. However, the biggest thing in allergic rhinitis is they need to be taken prophylactically. So usually patients that have, seasonal allergies know when their allergies are going to come about. So prophylactically taking Flonase or Nasacort before those symptoms might help. Antihistamines are probably the mainstay for allergic rhinitis because we know histamine is released from the mast cell during this allergic reaction. So by blocking histamine, we're going to block a lot of those very bad side effects, such as sneezing, itching, rhinorrhea, or the snotty nose, and stuff like that. The one thing I want to say about antihistamines is they don't really help with the congestion. That's why usually we're going to give an antihistamine with one of these other two medications here on the side. Now remember, antihistamines are going to block histamine 1 receptors. We have first generation like Claritin and Allegra, and second generations like Benadryl and promethazine. I said that wrong. First generations like promethazine and Benadryl, second generations like Allegra and Claritin. Your first generations, Benadryl, make you very sleepy, whereas your second generations, Allegra and Claritin, don't make you sleepy. That's why a lot of our patients usually want a more second generation antihistamine because they want to be able to function at work and school or whatever. So we're usually going to give them a second generation like Claritin and Allegra. Now, as far as our decongestions, one of a great example we see a lot is phenylephrine. What they're going to do is work on the alpha-1 receptors and cause a vasoconstriction. Well, if we have vasodilation in the nose and in this area, that's what causes a lot of our congestion and issues. Therefore, by constricting those vessels, we're going to get less congestion. Hence, why an antihistamine can't do congestion, we'll usually give it with a decongestant. The biggest thing when we give decongestants, like phenylephrine, we can give it orally or intranasally. Phenylephrine, typically obviously going to be nasally, is going to hopefully stick more to the nose or the nasopharynx area and less of the systemic effects, because we do know that when we're giving an alpha-1 antagonist, we can see alpha-1 agonist, we can see effects like increased sympathetic tone, which the patient might feel just kind of more awake and excited. Now, those are pretty rare and shouldn't happen too much with the intranasal, but people can abuse them and take a lot of those to try and get that. Now, one of the biggest side effects we do see with our decongestants, like phenylephrine, is going to be rebound congestion. The idea here is they take the medication for longer than 3 days. Once they stop it, they get really bad congestion. So what do? They go back to the phenylephrine, and it keeps on going. The biggest thing to prevent this is to do it less than 3 days. If you're only taking that medication less than 3 days, you have less likely to have the rebound congestion. Now, orally, one of the medications we can give is Sudafed or pseudoephedrine. Sudafed has a higher risk for abuse because by taking it orally, you're going to get more of those systemic effects like the euphoria or just that CNS excitation. That's why around 2008, the FDA has said that pseudoephedrine, true pseudoephedrine, must be bought behind the counter. For that reason, you must also have an ID. You can only get less than 9 grams in a month. And you have to sign a logbook. The reason for that is patients, if they get a lot of it, they can help make methamphetamine. So be very careful with that medication with your patients. Now, in general, with prescribing, like I said, antihistamines are kind of going to be our mainstay here, but they don't help with that terrible congestion we worry about. So we're usually going to add on a decongestant or a glucocorticoid. The nice thing is most of our common brand names in the store now, like Allegra D 12-hour or Claritin D 12-hour, are just that. It's an antihistamine for all those annoying side effects, but then one of these other guys for the congestion. Now, drugs for cough. Cough first, then we'll do cold. Now remember, the cough reflex is very protective. We have our irritant receptors that make us cough and get the bacteria out of the body. That's why patients that have a decreased cough reflex, maybe some of our neurologic patients, some of our older patients, don't have a great cough. Therefore, it's easier for bacteria to get down past all those protective mechanisms and sit there and cause a pneumonia. So for that reason, we're only really treating coughs in patients that have a non-productive, a cough that's very, very discomforting. Maybe they have that really harsh cough and their throat is just killing them. It's making them not be able to concentrate at work. They can't sleep, stuff like that. But if they have a chronic or a productive cough with COPD, asthma, or other obstructive diseases, that's not really a cough I'm looking to treat because it's a protective cough. And those patients are already at risk for infection, especially our COPD. By taking that cough away, we lose that protection completely and put them at even a higher risk for an infection like pneumonia. Now, when we look at our antitussives, which what we call our anti-cough medications, we have a ton here. Now, two of the most common you're going to see are opioid derivatives or non-opioid derivatives. Opioid derivatives like hydrocodone or codeine help decrease the cough. Now, the good thing is when we prescribe them for an antitussive effect, it's a lot less of a dose than it would be for the analgesic effect. For that reason, they go from Schedule 2 usually all the way down to a Schedule 4, meaning they're still at risk for abuse, but not as much as we were just prescribing them for an analgesia. However, in general, we got to be careful with these medications because they can get that euphoric effect. A non-opioid like Robitussin still has the effect, still has an antitussive effect. However, unfortunately, is because it's from an NMDA receptor, high levels of Robitussin can give patients the euphoria effect if they're looking for that. So we still need to be careful with these two groups of antitussives for risk for abuse. Robitussin is found throughout many different store brand anti-cough medications. Now we have expiritants and our mucolytics. When we look at our expiritants, like guaifenesin, which we commonly see as Mucinex, it actually makes the cough more productive, meaning we're actually going to stimulate flow of the respiratory tract secretions. So the nice thing about that is they help us, I always kind of like say like you cough better. You're more likely to get that gunk out of there. So things like Mucinex will help us be able to cough up that crap in the body. Mucolytics, on the other hand, kind of take that very thick secretions and stuff like that and break it down and make it a little bit more watery, thus making it easier to get it out. A good example of mucolytics are like hypertonic saline or Mucimus, which we know Mucimus we use sometimes for overdose of Tylenol. But the biggest thing with Mucimus is it does stink, as it always does, but it makes it more watery. I will add to be careful with antihistamines because we do know that antihistamines, especially Benadryl, has sometimes anticholinergic or antimuscarinic effects, thus making the mucus much more thicker. So it actually might make, you might be able to cough less, and it actually might make those secretions thicker, so we need to be very careful there. Last but not least, drugs for cold. Now, the common cold, there's still no cure. And there's really not great data that vitamin C even prevents or treats a cold. But what we do know is 80% of the colds are caused by rhinovirus. Now, we can give a lot of different medications. Nasal decongestants for just that really annoying decongestion they feel up here, like phenylephrine. Anti-cough medications can be helpful, but be careful. If you have a very bad viral cough, you don't want to suppress that cough too much because that might actually turn into a pneumonia. So you know, rhinovirus can do that. Maybe an analgesic if they're really hurting. Sometimes you give an analgesic that also gives you the anti-cough effect. Antihistamines are interesting. We know antihistamines aren't really doing anything for the cold, and there's really no reason to give an antihistamine outside of the fact unless you're trying to give the anticholinergic effect. Well, the idea here is when the anticholinergic effect might help dry up that mucus. But like I said, in general, remember antihistamines have an anticholinergic effect or antimuscarinic. It might make things worse, meaning that mucus that's watery, maybe a little bit easier to get out, might become very thick and hard to get out. Might put them at risk for that viral pathogen to just sit there and cause a pneumonia. Sometimes we'll see caffeine, and that's really for the negative effects of antihistamines, especially those first generations, and can help with headache in some patients. But in general, I want you to be very careful giving cold medication to any of your pediatrics. Both the FDA have agreed not to give cold medications, depending on what they are, over the counter for children less than 2 years of age. Now, the reason for that is a lot of studies have pretty much shown that they don't really give those great effects we're looking for, and those kiddos are actually at higher risk for adverse reactions to these medications. So if you look at the American Pediatrics and you look at FDA, most of them agree kids under 4 be pretty careful giving this unless it specifically says this medication is okay in kiddos. But it's always great for your patients to come see a provider, make sure they're asking questions and what medications are safe and not safe when treating cold in kids. As we know, cold and rhinovirus is very common in our kiddos. Last but not least, what I want to say is, again, under 6 years of age, just make sure you're asking your provider and they're coming to see us. We don't want to give antihistamines to sedate our child, like if you're going on a flight or anything like that. Antihistamines have been proven to cause sometimes more adverse reactions in kiddos versus adults. In general, just be careful with these anti-cold medications, anti-cough medications in kids less than 4 or less than 6 years or less than 4 years of age. Guys, that's all I got. Quick, down, and dirty. If you have any questions, leave a comment. Give me a like if you want, and I'll see you next time.